local UK-based trauma unit and an assessment of the current management and guidelines and evidence available for management of trochanteric neck and femur fractures. So we're based in the Royal Orthopaedic Hospital in Birmingham, and this project has been taken around the West Midlands region of the United Kingdom. So first and foremost, our aims are to assess the compliance with fragility hip fracture guidance outlined by the National Institute for Clinical Excellence, which is what we primarily use in the UK to guide a lot of our management, and to highlight any reasons amongst the cases that we've seen or in the research as to why those guidelines have not been followed. And at the end of the day, that they're a guideline and they're not a gold standard per se for every person's fracture. And these are some examples of trochanteric neck and femur fractures. On the most left-hand side, a relatively undisplaced one, in the middle, one that's clearly displaced, and on the right, one that is very displaced and the fracture line extends periodistal down the femur. And these are the sorts of cases that we would consider if we wanted to do a nail or manage this with a screw and plate DHS-like construct. So neck and femur fractures have been researched for a very long time. They are very common fragility injuries that elderly people will sustain. There is a UK incidence of around 65,000 per year and a global incidence of 6.2 million. I will touch upon the National Hip Fracture Database that takes a lot of our sort of data forward and guides our management, but essentially the 30-day mortality following this injury, whether you operate or not, is around 8.3%, and the one-year mortality is 30%, and that's an overall improvement of from 40% from the early 90s, and that's a well-accepted international figure. It costs the UK's health budget $2 billion a year to cover for the social costs and healthcare costs, and this covers 1% of the NHS budget. There were formation of registries to assess how we are managing this condition, which has seen the 30-day mortality drop significantly over the last few decades. Historically, extramedullary implants or DHS implants have had similar outcomes to intramedullary implants, but emerging evidence has changed our thought process on this, with note of IM nails having higher reoperation rate due to periprosthetic fractures, and extramedullary implants being less expensive and therefore are recommended for most trochanteric neck and femur fractures. The hip fracture database, which was outlined, created in 2007, covers all of the trauma units and trauma centres in the UK, and the engagement of that in terms of patient data has been pretty steady for the last few years. As you can see, the 30-day mortality had been dropping from 2012, and there was a slight increase in 2020, which was felt to be due to the effect of COVID. And there are some big studies that show that the mortality rate with COVID, with a neck and femur fracture, was up to 40% higher. So that will explain that increased contribution. There was also during this period a reduced interest in doing total hip replacements, especially amongst these unwell COVID patients. And as such, the NICE compliant surgery rate went down by about 3% in that year. So the injuries we're talking about are the simple per-trochanteric fracture patterns, and currently the NICE guidelines outline that the A11 and A12 types, which are the very simple ones, which I've highlighted in red, are managed by a dynamic hip screw, and all other fracture patterns are suggested to be managed with an IM nail. The one that causes a lot of debate on an individual patient basis is sort of the one A13, which is next to the red highlighted area, because the fracture pattern is quite similar, and the DHS is a very stable load-bearing construct, and surgeons are very comfortable in doing these operations regularly. However, due to the fact that they are extending subtrochanteric, so more than 2 centimeters below the left trochanter, the NICE guidelines recommend to do an IM nail. And this is classically where there is a lot of discrepancy with surgical opinion and practice. And here are examples of a DHS extramedullary device and an IM nail intramedullary device. This is a cephalomedullary nail. Here is some data from the National Hip Fracture Registry, which essentially shows to us that the number of cemented arthroplasties, so that's in the green line, has been, number of total replacements in the yellow line has been increasing slowly, and as I mentioned, was reducing slightly during that 2020 period and is now starting to pick up again. The number of cemented arthroplasties, which is the recommendation for hip fractures not to do an uncemented, as it has better periprosthetic fracture frequency and dislocation rate up to the 1 year mark. Beyond 1 year, cemented and uncemented has no difference. But in this frail patient group, a periprosthetic fracture dislocation can be quite fatal for them to potentially go back to theatre. So you can see that green line has done quite well, going well above 90% now. And then there's the purple line for the DHS for A1 and A2 fracture patterns, which has been decreasing. And that is what this project is looking at and is against the current evidence base. So our project was a retrospective assessment in a dedicated UK trauma unit, looking at their practice through their UK National Hip Fracture Database data. We looked at all trochanteric neck femur fractures, the 3 that I've shown you, between a period of 2020 of about 8 months. The exclusion criteria was patients under 65 years old, as you would try to maintain their femoral head in a young patient group, as opposed to going for a hemi or a total replacement. And we removed pathological fractures as well as cases clearly managed conservatively. This gave us a cohort of 80 patients where we looked at the type of surgery they had, assessed it for compliance to NICE guidelines, and then cases that did not follow the NICE guidance, we then further sub-analyzed to see what the particular reason for that discrepancy was. So looking at the results, keeping in mind the AO fracture pattern I've shown you, so the vast majority of these injuries were A1 or A2, 75 out of our cohort, and only 5 of the 80 were the A3 types. And our unit showed 93.75% compliance to NICE recommended surgery, which is much higher than the national average. And then looking at the 5 subtrochanteric fractures, these were all managed in line with the NICE guidance in having an IM nail. However, looking at them specifically, 3 of them had long nails versus short nails, which is another debate. And that may be because there was a patient history of malignancy, or there was suggestion of something pathological intraoperatively, which then precluded them, or the fracture pattern, making them feel that they wanted a longer stem to make it more biomechanically stable. And there is no current guideline as to whether a long stem or short stem is required. So that's absolutely fine. The NICE guidance that I've mentioned combines 4 main points looking at the study area we're looking at, known as a KPI 3. And this is essentially ensuring that your patient is having compliant hip fracture surgery. So those points are that for a subtrochanteric fracture, you do an intramedullary IM nail fixation. For an A1 or A1-2 simple trochanteric fracture, you use an extramedullary device such as a DHS. For a displaced intracapsular fracture, a cemented arthroplasty is recommended, either a hemi or a total hip replacement. And the choice of cemented total hip versus hemi is considered, not definitively done, but can be considered in patients who can mobilize independently with 1 stick, that aren't cognitively impaired and are medically fit for anesthesia and a total hip replacement procedure. Currently, there is no NICE guideline on the best way to manage undisplaced intracapsular hip fractures. And then the question is whether you fix them or do an arthroplasty. And there is a large multi-center based trial called the White 11, which is looking to answer this question. But presently, in a young person with an undisplaced intracapsular, you would probably do fixation to preserve the femoral head. In a much older patient, you would have an easier argument to do a hemiarthroplasty or a total replacement to give them one definitive operation and avoid them having to come back if their femoral head goes into AVN, which has a risk in an undisplaced fracture pattern of about 20%. Just looking at the wider research for a second, there was a large Cochrane review by Lewis from 2022 comparing cephalomedullary nailing and extramedullary nailing. So as expected with large Cochrane reviews, it didn't give any overall definitive answer, but it gives you a number of things to think about when you are facing these patients and your choice of surgery in future. So it combined various randomized controlled trials and quasi-randomized controlled trials. So these are trials that did not have a true randomized method for the patients in allocating them to various groups. And they looked at various outcomes as noted there. So activity of day living, delirium, functional status, patient-rated quality measures, mobility, mortality, and an unplanned return to theatre for a complication. And there was low evidence of difference between the two groups, and this was based on only one retrospective study. Looking at the IMNL versus DHS mobility, when you've adjusted it for Parker's mobility scale, there was a slight improved mobility index with the IM nailing group, and that's across 14 studies of 1,700 patients. And the I2 is a heterogeneity scale. So this was fairly heterogeneous data. So, up to 63% of 100% is quite a lot. So you can take it with a pinch of salt. But there's little evidence of difference between the two surgical arms. If those patients achieved independent mobility, then they tended to do exactly the same. It was sort of a plateau at that point. There's an increased risk of intraoperative periprosthetic fracture as well as post-op periprosthetic fracture with IM nailing versus DHS. And IM nailing had a slightly higher non-union risk versus DHS. But new evidence looking at mobility and walking speed gives IM nailing the edge. So the jury is still out in that regard. The best practice tariff looks at a incentivized method of pushing national guideline standard of care. And this is a sort of pay for performance initiative that's been used in many healthcare systems to drive improvement. And the UK has done this through the best practice tariff to incentivize and adequately reimburse providers who achieve these 6 parameters. And looking at these columns, most of these are doing quite well, above 80%, but the light blue line here, which is prompt surgery within 36 hours, is proving to be the biggest drawback, and is obviously something that needs to be addressed with availability of services. And overall, because of that, current percentage achievement of this in all of those 65,000 neck fractures in the country is around 42.5%. So we've definitely got a ways to go. There is the BOSE guidance, which is more actively cited and used by orthopedic practitioners in the UK over the NICE guidance. And this is the BOSE guideline 1 for, so this is the first one they ever did, which is for hip fractures and was updated in January 2012. And although it does advise hospitals to submit national hip fracture data, it's disappointing that it doesn't comment on the choice of surgery for the given fracture patterns like it does in the NICE guideline. And I think if the BOA would agree to putting some of those principles in their actual literature that they give out, I think that would have a lot more impact on swaying orthopedic surgeons towards following certain evidence-based management principles. So in conclusion, our unit had compliance with NICE guidelines to manage trochanteric neck fractures. Non-compliant cases were treated with IMNL fixation for A1-2 fractures, although there were none of those in our unit, but that is what is happening around the country. And in our group, no A3 or subtrochanteric fractures were treated with DHS, which I think is is very reasonable, and that's what should be happening. The classification system, as I've said, is limited, and the X-ray features demonstrate why an intramedullary device was chosen if you're present in the meeting, but it's not present on the actual op notes. Various fractures don't neatly fit into either class, especially if you have comminuted intratrochanteric fractures that wouldn't fit with the kind of scales that I've shown you for AO classification, and therefore there is still some scope for independent opinion for managing borderline cases. But I think it's important that we really manage these non-borderline cases appropriately. So that's my presentation. Thank you.